two national resource centers serve as a focal point for advancing the effective use of the telehealth and supporting access to telehealth services in rural and underserved communities. Today's presentation is being presented by the Southwest Telehealth Resource Center. I'd like to introduce Kimberly Shea. Kim has been a nurse for over 25 years and a researcher for the last 7 years. Her research combines the patient focus of palliative care with the the efficient development that telehealth provides. Kim is the assistant director for telehealth nursing for the Arizona Telemedicine program. Kim has been a participatory member of the Tucson community for the past 35 years and has 4 degrees from the University of Arizona. Welcome, Kim.
Hello. Well, it's nice to be here with everybody today. And as Chris said, I have a background that combines both my love of palliative care and symptom management with a new adventure which happened years ago, which was to look at why people that were high touch were not necessarily interested in technology. So what I did at that point was had a master's in informatics, because I really wanted to look at that theory and thinking behind why do people not want to use technology when they do health touch? Can it help them improve their care? Can it deliver more expedient, more efficient care? And so after getting that master's in informatics, I decided that was not necessarily my forte. I was not a high-tech person, but I combined them for my Ph.D. work, and that still drives me today. And I have been involved with telehealth and the Arizona Telemedicine program for probably the last 10 years, and really have used telehealth in many ways. But today I'm going to talk to you about symptom severity reduction in palliative care and how we can use telehealth towards that means. So what it will involve is a lot of discussion on telehealth options and palliative care and symptom management. So first, I do want to have us have an agreed upon definition of telehealth. This is a definition from the Health Resources and Services Administration, which is also the primary federal agency for access to healthcare services for people who are uninsured, isolated, or medically vulnerable. And their definition is telehealth is the use of electronic information and telecommunication technologies to support long-distance clinical healthcare, patient and professional health related education, public health, and health administration. Through this talk, I really would like to focus on telehealth, the beginning of that, which is the use of electronic information to support long-distance clinical health care. So one of the things I wanted to see is what directions are we using telehealth towards? So 2 journals that are very familiar to all of us involved in telehealth is the Journal of Telemedicine and Telecare and Telemedicine Journal of eHealth. These 2 journals, there was a review, a review of 60 most highly cited publications. And why do we do these kind of reviews in different areas? Well, these reviews are done really to assess the direction of what kind of work is being done in a certain area, or to identify progress over time. And the review showed that there is a current trend, obviously, because the majority of the articles were toward mental health and home-based health using telehealth. In that review, they came up with the 5 most common categories, and this is a combination of the 2 journals. in general, 57%. In general was things like theory, definitions of telehealth, the use of telemedicine. This teledermatology and telepsychology were the second two most used types of telehealth. Telehome care and telemental health also were used. Now, as you can see, these are combined numbers. So combined telehome care was 20%, which I find interesting because of those that use telehome care, the technology is not necessarily supported by funding by Medicare and Medicaid. It's the services that are provided. So when you look at these 6 or 5 most common, I see 3 of them, such as telepsychology, telehome care, and telemental health, contributing to what we see as important for palliative care. These are options that we use for telemental health and telehome-based health care. Web-based education, real-time audio, which we all know is the telephone, patient or provider initiated, could be either communication directions or conference calls. We have store and forward. Telemonitoring has become a real big source of use of telehealth in the community. Telemonitoring is something that patients can do every day. Nurses review their information and they can call and see when things are starting to decline and do a just-in-time rescue. Real-time visualization, which is my favorite and what we're kind of doing as we talk here today, and televisits are real important for home-based health care. And these can be stationary visits, such as what we have today, where we're sitting in a stationary face-to-face meeting, or the more unused type of telehealth for home care is the environmental visit, where you can actually take an iPad, take some sort of smartphone and walk around and show your environment that you're living in, show how your setup is for your devices in the home, whether your durable medical equipment is near a window, where your bed is, etc. So these are devices that are pretty familiar to all of us. We use them every day. We computer with internet access, we use telephones, we use smartphones, and we use tablets, which are iPads and other Android tablets. So this is nothing new. And you can see why telemental health and home-based health care is perfect for the use of these kinds of phones and this use of telehealth in the community. But I'm talking today to you about palliative care, and I'm talking about how that intersects with telehealth. So I went to those 2 journals using the same search techniques that they used in the article that was in the Journal of Telemedicine and Telecare to see what we could find for telepalliative care, or just simply search those 2 journals for palliative. And as you can see, since 1998, which is how long the journals have been in existence, there's 12 articles in the Journal of Telemedicine and Telecare, and there's 4 in the Telemedicine Journal and eHealth. What do these articles, or do these pieces of information tell us about the use of telehealth for palliative care? Well, it tells us that it's used for out-of-hours telephone support, on call, for calling the nurse, and that's primarily telephone. That's something we've been doing for a long time in hospice care. And additionally, advice services for patients, their carers, and health professionals are available through telephones. And also, we now have opportunities to visit with them through email and through the web. A third use was video conferencing for case discussions. In hospice and palliative care, we need to have interdisciplinary meetings. That's very important to make sure that all the people that are involved in care can come together. Great use of telehealth. And then training and education are the other ways that the telehealth journals were publishing information about telehealth for palliative care. So what is palliative care? Now, I want you to think about what telehealth offers us from the perspective of the devices that I showed you while I'm talking about palliative care. And I think you will come up with the same conclusion that I have, but if not, we can discuss it at the end, because I'd like to leave time for a discussion with questions that you can send in your questions about the merging of these two types of care, telehealth care and palliative care. So palliative care, and this is a definition from the World Health Organization, very recent definition, is care that improves the quality of life of patients and their families facing a life-threatening illness through prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Now, who can receive palliative care? It's appropriate for anyone who's suffering from a serious chronic or life-threatening illness. And I have on the screen there different types of illnesses, and you can see it's not all cancer. As a matter of fact, that's one of many. And the thing about palliative care is you can receive palliative care at any age and at any stage of your illness. So you have a diagnosis of an illness that is life-threatening, but throughout, that could be a very long process. I mean, if you want to look at this very esoterically, we're all on that continuum. We're all headed in that direction. The target population for the current palliative care programs are towards people that are driving the runaway medical spending. And we'll look a little bit in the next slide of actually who those people are. But people that are continually returning to the hospital because they have a life-threatening illness that they need to manage. Palliative care is treated in the same way as medical service, such as if you were to get a cardiology consult. But the interesting pieces that I just talked about is how people live, and the importance of the definition is this is about people's lives, about their quality of life, about their care. And for most of us, that's at home. That's not going into a clinic. That's not going into the hospital. And so you question the fact that palliative care is treated primarily in a hospital and not a specialty service that goes to the home. So who receives palliative care? Well, let's look at the numbers, and this is from the Center to Advance Palliative Care and the National Palliative Care Research Center. They have a document that they do a report card and look at palliative care, and they post it, and it's on America's Care of the Seriously Ill. And we find that even though there's only 5 to 10% of patients that are seriously ill, they account for more than half of the nation's total healthcare costs. Additionally, when you get a serious illness, or maybe you have this before, they can be before or after, you generally have other comorbidities or other illnesses that are either a result of the serious illness as your system starts to break down, or from medications that you're receiving, or you've had several comorbidities and now you have a serious illness. But all of these together account for 2/3 of the total Medicare spending. The 4% of the sickest Medicaid beneficiaries, now we're talking about Medicaid here, account for a full 48% of the total spending. And 76% of the national Medicaid budget goes to acute hospital services, which is the most expensive setting of care. So you look at all of that, you think, wow, why are palliative care services offered to inpatient people when they come in? And why is that something that we don't necessarily provide as a specialty that goes to home? Well, it's expense, right? So what is palliative care? It's an approach as we already talked to this about this definition, but I want you to see and look at the bolded print here. It's through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems. We can do this through managing people's symptoms, their physical symptoms. What we've seen with telehealth so far is it's very good for psychosocial, for psychology, for mental health, because we can visit with people, we can help talk with them, and the visual nature of seeing people is very helpful for mental health, for psychology. And we can use the monitoring aspect to look at people's symptoms. And their symptoms are things that we can monitor only, like vital signs is primarily it, or weight, or blood pressures. But what about symptom management when you're looking at it within the confines of palliative care and how we manage those symptoms? Well, I looked up the definition from the National Cancer Institute of really what symptom management is. And you'll notice my sources are from various places, and that's because I wanted to get a big perspective. And their definition says that the goal of symptom management is to prevent or treat as early as possible the symptoms of a disease, side effects caused by a treatment of a disease. And again, we have the psychosocial, the social, and the spiritual problems, which are related to the disease or its treatments. So now let's look, what are symptoms? What are symptoms that we're treating, and why might telehealth be a good opportunity to treat symptoms? Well, these are all very common symptoms that we work with in palliative care. I tried to keep the more physical ones on the left and the more emotional or psychosocial ones on the right, but I was running out of space. So anorexia kind of snuck over there onto the right side. But every one of these symptoms, as you look at them, you can think about what happens when these symptoms continue over long periods of time. One in particular that I think many people can relate to, and it's just an example I'll give, is insomnia. You know, you start not being able to sleep well, you progress to not sleeping well, it goes on for weeks. Pretty soon you have depression risks, anxiety risks, those things then sequela out to perhaps maybe bowel problems, maybe fatigue, obviously fatigue, nausea, and vomiting. So you can see the vast importance of treating things early, because what we want to do in palliative care is have a quality of life without letting these symptoms get away from us. And early treatment is absolutely critical. These are questions that I thought were very insightful questions that could be asked remotely, but I also think if you had an opportunity to have a visual interaction with people through telehealth, they would become, and their answers would be so much richer and so much more full of information for you to treat people. These are questions that were on the University of California in San Francisco HIV Insight website. And I think they're very insightful, because something like, how are you doing with your adherence? Well, medication adherence or adherence to treatment, many people will avoid them because they experience side effects. They don't want the side effects. The side effects are wreaking havoc with their quality of their life. Diuretics in particular. I can't go out because I have to urinate all the time, so I'm going to avoid that diuretic. But having an opportunity to talk with people face-to-face through telehealth, as well as look around the house, see what the environment's like, and adverse effects are the other part. people make incorrect or correct assumptions, especially when facing a serious illness, because this is something new that's going down a trail, and things are changing constantly. Things are moving. It's not a static condition. So is it from the medication, or is it from the illness that I'm experiencing this? And I may just assume it's from the illness and there's nothing I can do about it. But this kind of question with somebody in a visual nature, you could really pick up on, maybe this is from the medication they're taking, and we could change that medication, and they don't need to have those adverse effects, or they can be altered as to when they take them, what time. And then simply, how are you doing in general? Patients may report specific life stressors and things that you can then pull back to their quality of life. So the state of the science statement that the NIH made about the National Institute of Health, about a symptom management process, is that it is much more than just a simple physical assessment, because you can't do it at a one point in time. You need to start when the diagnosis is given and consider all the pieces: age, how long is this person going to live? Is it worth it for them to get all this aggressive treatment? And they're only going to live, they're 87 years old. So the home environment, looking at what people's life's goals are all part of the symptom management process. And again, repeat frequent assessments. And this is what really speaks to me about the symptom management component that we need to look at for telehealth and palliative care. Early intervention before symptoms, before the symptoms cause the problems. And this one I found very interesting in the state of the science statement is, and relates to frequent conversations, is establishing a common language for facilitating communication and improving treatment. And those of us who see patients frequently can relate to this. People speak and describe their symptoms and what's going on in a very different fashion from the next guy. And so once you get to know your patient and you're talking to them frequently through telehealth, then you will all of a sudden know what the common language is between you, know how this person reacts to symptoms, know what they will do and what they won't do. And so this I think is a really important part of managing symptoms. Well, I'm back to the definition, and I bring this back to you because we can't forget about quality of life with patients and their families. And so I looked up quality of life because quality of life has been something researchers have been trying to be able to measure, to give information on, to determine whether somebody has quality of life, whether they don't have quality of life, for a very, very long time. So one of the definitions I found is that quality of life is the patient's ability to enjoy normal life activities defined in terms of health and happiness, not wealth. So again, pull this back to the frequency of being able to visit with people in their homes. What are your happiness requirements? What does it look like in your home that you value? Is there a lot of windows and openness? What is it that are your happiness requirements? Can we fit the telehealth options for visiting you? We have different options to prescribe for telehealth. Can we fit them into your definition of what your happiness requirements are? Then another definition said that its quality of life is the standard of health, comfort, and happiness experienced by an individual or group. This, to me, brings in the entire family. As palliative care focuses on the entire family, people do not often live in isolation. I say often because occasionally you're going to meet a few people that prefer isolation. But in general, as your health starts to fail, you can't live alone. And so the group that you live in, whether that's family, whether that's nursing home, that is something that also needs to be assessed on a frequent basis to see where is that going? How is that support needed? What do they need for support? And by offering palliative care where you have to go to a hospital or go to a clinic, you don't see that. You don't see the family environment. And often the family can't come with you. The carer is, for whatever reason, not able to come to the visit. The children that are in the home that are running around with grandma, you don't even know necessarily how much interaction exists unless you can use some sort of telehealth support. So these are things, when we think of telehealth care, are very central to telehealth care. And yet I think through my discussion of palliative care that I just went through and symptom management, you can see how each one of these that telehealth care does extremely well or has the ability to do well speaks to that palliative care. I did a lot of talking on time. That's time spent, time traveled, time it takes somebody who's not feeling well to get up, get dressed, get to a clinical visit for palliative care, all of those pieces. The providers don't have to travel, if you do have home health, to the patient's home, which takes an enormous amount of time and decreases their productivity. Frequency goes with time. You can do much more frequently when you have the time. And then communication. We talked about the importance of communication when you have the opportunity to visit more frequently and to talk to and get to know people and know what their home is like, their environment. And I love visualization. I work a lot with the theory on visualization where it talks about senses. And the senses, the more senses you have involved in communicating with people, the less anxiety they feel, the more trust they have in you. And consequently, when we talk on the phone, we're just talking with our verbal senses as well as our auditory, and visualization is one step beyond that to helping with trust, helping people to know what we're about, and being able to understand through communication. Safety is huge with travel. Once you start to bring in travel, especially in people, I'm very fortunate here. I'm in Arizona. I very rarely think about travel related to safety, but in some other climates, and I'm sure many of you are having the start of bad weather and snow, that is a huge factor when it comes into when you're dealing with people who are not feeling so well or being cared for by elderly other carers. And then safety from the other perspective of being able to look around a house, look around a room, see. As nurses, when we go into the home, that's almost intuitive to us. We can spot a throw rug a mile away, because that's something somebody's going to trip on. Somebody's going to slide, the walker's going to hit. Those things come out as quickly as you can get them out. Little steps, when you're placing somebody's hospital bed in a home to take care of them, you don't want them by the steps that somebody's going to, people have these tiny little steps. You want to make sure that you don't have any more increased ability to trip over that little step. Just all kinds of things that if you're aware of them, oxygen tubing, how it flows around the house, and how, is it a trip opportunity, because people do use really long oxygen cords to keep the noise of an oxygen concentrator in the other room, because they are loud and they want to stay in the living room. Collaboration, we talked about collaboration from the importance of an interdisciplinary team and being able to talk. Privacy, we work really hard with all the HIPAA information, but the thing that's interesting to me is that if you do a telehealth visit and it's not stored anywhere, it is very HIPAA compliant. There is no way anybody's going to be able to get into that if it's not stored, if it's just passed through like, this, I don't know, this is probably being recorded. But if I'm just doing and we don't use Skype because Skype is a public domain that can be used, but there are other meeting softwares that don't have the ability to video record a meeting, and it's just as if you were talking with somebody in private. Again, the importance of being home-based, and many of our treatments now are outpatient. People go home right after surgeries. And then last, but certainly not least, is it's patient-centered, patient-focused. You're in their home, you're with them, you're considering all their quality of life issues, you're considering their lifestyle, as well as what types of environments they are living in, as far as, ability to get all these things that you think are so important. Can they even bring that into their home? Can they even afford it? So I pulled up the options before, and we looked at the options for treatment using telehealth. So those are on the right. This is my kind of personal commentary on why we really need to think about implementing telehealth to palliative care as they are both expanding together. And the reason is, I believe we have many services now that are established services, and what we do is we look around for the best gizmo that we can fit into an established service. Instead of starting with that technology, or that gizmo as I called it, already as part of the service. Already as so we're not trying to fit things to already established, or we're not trying to build around a technology. We're doing it at the same time. Palliative care today is not home-based. Wouldn't it be wonderful if we could use this opportunity to create a service designed with telehealth right from the beginning? And then we could order patient-focused healthcare or telehealth treatments using these options. Look at the individual, look at their quality of life, look at what they're how they live, and look at what treatment options, obviously what their connection abilities are. I, through the help of the Arizona Telemedicine Program, did a usability evaluation with iPads in the home, and we put service right to the iPad, so we wouldn't have to worry about the Wi-Fi availability within the home, because not everybody, as you know, especially people that we're treating in the home, have the availability of Wi-Fi. So if the cell service went right to the iPad, it was always on, and it was just a click to do a meeting. So those would be things that we would build in to our original palliative care assessment and create a package that could be changed, that could be altered, instead of trying to take a technology and fit it to a service that's already being used. The other thing I think is an interesting concept. Well, first of all, the treatment could obviously progress as the patient progresses. So in the beginning, maybe it's just web-based education as somebody learns about their illness, as somebody learns about what they need to find out from the internet. Then we could have telephone follow-up. But as they get more and more homebound and unable to leave the home, that's when we can start the televisits with a real-time visualization. But the interesting part of this is we can dose just like we would do medication for telehealth options. So we can schedule it at a daily time we would want to meet, or they would want to do something with telehealth. Or we could use it as an as-needed opportunity, or we could have some combination. But doesn't that sound like their regular treatments, their medications that they could use, that would be part of the process right from the beginning? So I kind of went through that faster than I thought, but I think our clock here is a little slow.
Yeah.
Okay, good.
You're good.
Okay, so the conclusions I have come to through this, that I want to try and pull all these thoughts I have and directions I would love to go with this, is that telehealth science is currently focusing on home-based psych and mental health. That's from the literature review, that is the direction we find the most cited articles. So it's there. Those are things that fit with our palliative care. Telehealth uses and its goals, fit with the purposes of palliative care. When we read the definition of the goals and the uses of telehealth, they dovetail very well with what the definition of palliative care is. The devices that we would need are pretty common. We could certainly find at least one of those that would fit with what our clients need. Palliative care focuses on quality of life in the home and is needed by a vast majority. We looked at the numbers of people who are experiencing or fit the need for palliative care, and we could create the telehealth focus to meet with their quality of life. Patients who would benefit from home-based palliative care are also those who are most expensive to the system, the healthcare system. As much as I would love to just be all about quality of life and symptom management and how wonderful that will be, the reality is money drives the system. And so we have that component when we're using telehealth for palliative care. And Medicare coverage for remote symptom management or telepalliative care, which is not well used in the literature, but certainly has an up-and-coming ring to it in my book. It could greatly decrease costs. So the addition of symptom management as a primary intent of telepalliative care is valuable. Reducing symptoms and the symptom severity is something that we need to do early, and it is valuable. And everyone would benefit from it being added as a treatment option for palliative care. So that's my presentation to you, and I would love to open it up to questions. Chris is here to help me.
Hi. I think Becky has.
Yeah, we've got some questions that came through on the chat. The first question we got was, can you go back and define impeccable assessment?
Don't you love that? I love that within the definition of, and as having been a hospice nurse, and I work right now with a wonderful team of palliative care providers at a local hospital, which is Crondelet Healthcare. I don't know if I'm allowed to say that, but it's a wonderful, wonderful program. And impeccable is necessary because if you do not look at all the systems, and another reason to me it fits well with telehealth is it means thorough. It means, to me, impeccable means you don't miss parts of it. You don't forget, because it all comes together in a big picture. And without that, with the telehealth component, you could add that extra piece of where do they live? How do they live there? What is their home about? Because that's really where we're going with quality of life. So I would say impeccable in my definition is thorough, not missing any opportunity or any avenue of assessment, be it symptoms, psychosocial, or spiritual.
Great. And then a couple other questions that have come through on the chat. One kind of a comment, excellent presentation. It seems to me that there are two delicate balancing acts to consider. Number one, the trade-off between the patient and the family's comfort with their own or native devices versus the data security gained from providing any agency-owned devices. And number 2, tension between the care plans driven by the patient's goals and self-defined metrics of quality of life versus the tendency to follow treatment protocols based on best practices and reimbursement. Please discuss the best middle road for both of these.
Okay, that's a great question because it has so many parts of it that I don't remember all the parts. So you'll have to help me there, Becky. Can I answer the first one without?
Sure. Okay, so trade-offs between the patient or the family's comfort with their own native devices, and then the security, the data security of a agency-owned device being provided to the family.
Right. So we talked about telephone. Obviously, telephone is something that it could be stored, I suppose, if we had somebody recording the call, but people have been talking on the telephone. So it's interesting that we don't even consider telephone as something we're worried about for HIPAA. We consider that a secure private device. So that one is pretty straightforward. But as far as their cell phones and smartphones, any smartphone can use the meeting software that I have used. And that is a software that I buy because it is HIPAA compliant, because it is not owned by any company that they store, and it doesn't even have an option to store. That can be put on anyone's phone. So it can be downloaded to someone's phone or iPad, and then it's not saved. It's the software that's the issue. So by us providing the software to the people to use on their native devices, we can be comfortable with the HIPAA compliant issues. Now, the problem a lot of times, as we know as providers with telephones or with smart devices, it depends on where you use them. If I use them in the elevator with everybody standing there looking over my shoulder, it's obviously not going to be private and their data and information. So it is going to require that providers on the other end, although it's spontaneous and we can do it immediately, we need to be very aware of where we are, both as the patient and as the provider, so that we can be using that HIPAA compliant software that we work so hard in a HIPAA compliant manner. Does that help? Did I answer the question?
I think so. And then the second part of that was the tension between the healthcare plans driven by the patient goals and self-defined metrics of quality of life versus the tendency to follow treatment protocols based on best practices and reimbursement policies.
Yeah, I hope my palliative care colleagues are listening. They could probably answer that really well because they deal with that all the time. And, you know, people go home, they're on board with palliative care. They're really, you know, they understand what their quality of life goals are and how different treatments will fit into it. And then they go home and they're not followed through with palliative care. So different things get segued. Other people will come in and order things that they may, and it's not a sneak attack. Nobody's trying to do this subversely. It's just that there's so many things to consider when you order a treatment to somebody that many times it's hard to bring all those factors in unless that's what your business is. And that's, I think, the problem with you know, so many treatments being prescribed or being willing to be paid for by Medicare or whatever. The treatments will be paid for, but this nice visit from hospice on a, you know, a medical device in the home maybe won't be paid for, and yet it costs much less than that expensive treatment that is maybe not fitting with your goals, but you don't know all the details because it's just too much. It's too much to know as a layperson, knowing what all the treatment components are, and it's too much as a specialist to know what the patient's home environment and goals are. So, enter palliative care, which is right in the center and can blend those. Use telehealth, and it costs less. So that's my summary.
Mm-hmm. Have you been involved in telechaplaincy in the focus of body, mind, and spirit, or has this come up as a research component?
No, I haven't, and I have read about it. It has come up as a research component when I have looked at primarily remote services, places that are very remote, and the chaplain getting to their house is just very difficult. And in most cases, it's, again, we call telehealth using the telephone. And I'm always surprised when I think I find it. Yahoo, I found something on visualization and using visualization, and then I read it and it's just a telephone. And I shouldn't say just a telephone call, but I'm always surprised that it's in that basket. The part that I would like to say is telehealth use in this way is often driven by the need for things in very remote areas, as well it should be. But I don't see, and having done on call at night, having done many different things with end of life care, I live right in the city and I see people that are right in the city. However, it still takes me a long time to get there. It still takes me time to finish whatever it is I'm doing to get there. And maybe a quick conversation right then would reduce anxiety in the caregiver, reduce anxiety in the patient, and show what the symptom need is right away. And it's a short jump start to that visit that I will make, but I can jump start it by having things not get away from me. I can't stress enough the importance of timing when you're dealing with symptom management and patients that are trying to not suffer from different symptoms that they're experiencing.
Yeah. I have a question. Are you willing to share the name of the software that you mentioned that you use?
Yeah, I'm sure there's many out there. The one that I use is called LifeSize. LifeSize, and I think they've merged too, but if you Google LifeSize, it will take you into whatever their merged structure is. There's some qualities to it that are very important. Not only is it HIPAA compliant and used in a lot of different ways to communicate with people where you cannot save the video, but it's also something that is really well done in being able to instantly connect. It's a very simplistic software where patients basically just push the button and it calls me on my iPad. So I don't have to log in. I have already put them as a person that I see, my iPad sees as a safe person that I know. It's like a phone. And so yeah, LifeSize is the name of that software.
There's one comment that there are many rural hospitals who lack palliative medicine service. And is anyone exploring palliative telemedicine to link rural to tertiary hospitals to meet this unmet need? And then one of the other people that is on the call said that Gunderson Health System in Wisconsin is doing palliative care to spoke sites.
Yeah, and I'm pretty sure I know who that might be who made that comment, because Gunderson has been one of the primary palliative care institutions in the country, and they have also the Gunderson where you look at end of life and questions and how do you speak to people about end of life, advanced directives, etc. Was there a question or what?
No, those are just comments, I think. And then I had one other question. Well, I'm going to combine two questions. What are the barriers for reimbursement of services, and how do insurance companies view those charges?
So barriers to reimbursement. Right now, palliative care does get reimbursed when people are seen by specialists in the hospital. It is a Medicare component, as a specialist would see anybody when they're in the hospital. The facility that I'm working at with the palliative care team, they have a great trigger system in which they look at all of the people that may be needing palliative care. It triggers when they come in. So then it's the hospitalist or the other specialists in there working with the palliative care team to look at what is needed in this case. So that's reimbursed. But once the patient leaves the hospital, there is no reimbursement for home-based care. Mm-hmm. Now, if they want to come back in and we had, say, a palliative care clinic, just like any other specialist might have a cardiac clinic. But as people move down that path, you can see the obvious, which is people become less ambulatory. Mm-hmm. Their quality of life would be enhanced if they didn't have to leave their home, or they had, say, a telehealth clinic that was right by them where they could, go to that clinic. And then telehealth to their palliative care experts, mm-hmm. which would be in rural areas. I think that would be really helpful in rural areas.
Yep, and then the follow-up to that is, so knowing that a home-based reimbursement is not currently available through Medicare, how can folks best advocate for Medicare coverage of telepalliative care?
Wow. Maybe you know that, Chris. I would love to know that, because that's my new venue. That's where I'm going. This preparing as a researcher, I've looked at different ways to make it come together. But as a community-based person that really wants to get this moving, I've now moved into a different domain, but I'm new to it. So maybe Chris would have some.
Every year they look at CMS looks at the CPT codes and such, and you just basically have to lobby and submit and resubmit and get the groups and get it from all across the country to state to CMS the need for that. And then they will look and review. It's a long process.
And one of the things I looked at on the site, the American Telemedicine Association site, that's always fascinating to me, is they have, by each state, you can pull up what services are offered and covered in that state. Now this is not Medicare, this is specific to states. But it's always fascinating to me which states provide some things, and some of them you can see, that's similar. I could see how we could segue that, building on what they're allowing in that state, and then once we can maybe get it into Medicare and build it on, then maybe as our Medicaid, we can then maybe move it over to Medicare, and as Chris was saying, just continually put it on there as something that would be, to me, our next topic is telehealth in skilled nursing facilities. It's a no-brainer. Well, I believe that this is a no-brainer too. When I looked at that title, I thought, you could say that for palliative care to me, just because of the wonderful fit between the two. But yeah, now I've got to get on the bandwagon and start moving towards promoting this in my state for sure.
Yeah. There was one other question, and I know we're coming up on the top of the hour, but just to follow up on the advocacy, I would say definitely get involved with the American Telemedicine Association, because they are strong advocates and they're always working to get more care. And then one question about the chronic care management reimbursement, the 99490, and can this apply to be applied to the telepalliative care? That's a thought. If it's a chronic condition and it's monitoring, I think that absolutely, you just have to track the 20 minutes per month with that patient, and you could get reimbursement that way.
Yeah, and I love, I mean, I've been in hospice a long time, and palliative care was always associated with hospice care, and and so people would say, oh, I don't want palliative care because I'm not ready to die. Mm-hmm. However, the definitions that we use now, as well as the fact that it's available when you go in the hospital to every single person, really helps to redefine it as something that can be, as that definition showed, done at any age and in any state of a condition. And any chronic condition, I mean, I could respin this in a million ways to make it a chronic condition, because any chronic condition eventually can become end of life. I mean, and be a life-threatening illness if it's not controlled or if it's not taken care of. So, it's all a matter of, to me, often of spinning the words correctly to show how broad the definitions are and how inclusive they should be.
I wanted to just add what Becky was saying about the American Telemedicine Association. You don't have to be a member of the American Telemedicine Association to use a lot of their resources. So I would definitely encourage you to go there. And each state has a wiki page that really goes into a lot of detail of what's offered and what's available in your area.
Okay, I did put into the chat function a SurveyMonkey link. If you would fill out the survey for today's webinar, we would greatly appreciate it.
Well, thank you all for attending, and it's been a really nice opportunity for me to pull this together and talk to you about it today. Thank you.
Thank you all.